Move on. Next speaker is Dr. Binto Mathew, please.
Good evening, all. Warm greetings from Caritas Hospital. Retaining a surgical sponge or instruments is really a nightmare for the surgeons. We have to take care of the patient. Same time, we should protect ourselves, also the index surgeon who performed the primary surgery. Here, one 35-year-old lady whose story starts 1 month back, who is a para 2, living 2, had 2 cesarean sections in the past, admitted in the peripheral hospital on the 37th week of gestation of the 3rd pregnancy with premature rupture of membrane, and delivery was conducted by the gynecologist, and later patient developed hypotension, then diagnosed as postpartum hemorrhage. The cause was retained placenta. So they contemplated emergency laparotomy, hysterotomy, and placental removal. And next few days, patient had a severe pain abdomen and fever. On the 5th day, patient shifted to another hospital, where they evaluated with ultrasound abdomen and CT abdomen and diagnosed as periuterine hematoma with a few air pockets. And they treated it as infected hematoma with the broad spectrum antibiotics, and patient got subtle improvement and discharged on the 7th day. 2 weeks later, patient developed persistent pain abdomen, and they consulted a new gynecologist at the hospital, where they took ultrasound abdomen that shows mass lesion posterior to the uterus with air pockets, suspicious of foreign body. Then they referred to us. When patient came, patient was hemodynamically stable, febrile, and abdomen was soft, a palpable involuting uterus in the hypogastrium, and tenderness in the lower abdomen. We advised detailed evaluation with the CT abdomen and followed by surgery. But at that moment, patient was not ready for the admission and went as LAMA. Next day morning, patient presented with a mass per rectum, a cotton foreign body partially coming through the rectum. And this was the sponge, surgical mop, partially expelled through the rectum. And we did exploratory laparotomy. There was pus mixed hematoma in the pouch of Douglas, walled off by the sigmoid colon, transverse colon, cecum, and appendix, with a few loops of small bowel. And distal sigmoid was gangrenous and a portion of wall eroded by the surgical sponge. And tail portion of the sponge was removed merged with the abscess. And another perforation noticed distal to that. We removed the foreign body and contemplated Hartmann's procedure. This was the dual perforation and partially gangrenous sigmoid. And postoperative period was uneven fold and discharged comfortably on the 8th post-op day. 10 weeks later, we did laparoscopic colostomy reversal. And here, the retained surgical sponge causes 2 kinds of reaction in the body. Initial phase, there is acute inflammatory exudative reaction and followed by the abscess formation. Later, aseptic inflammatory reaction that leads to mass, which can stay asymptomatic for months, even for years. If it is symptomatic, it will present with obstruction, peritonitis, adhesions, fistula, abscess formation, or even erosion into the GI tract, and to present as intestinal obstruction or even pass via the rectum. The exact incidence is not known. The current estimate of retained surgical items in 1 in 10,000, and surgical sponge accounts for the majority of the foreign bodies retained. And it is considered as a never event. It should always be prevented at all cost. A simple and effective surgical safety protocol like WHO checklist should be followed. And counting, always counting. Count performed prior to the start of any procedure, at the time of addition of a new item, prior to closure of a cavity within a cavity, at the time of closure of incision or skin closure. Thank you.
So, nice presentation. Why the patient went on LAMA?
The patient was not ready for admission.
So did you disclose the pathology?
Yeah, we advised, we have explained all the consequences, but patient was not ready for admission. They told that they will come on the next day, but unfortunately patient came with a foreign body through the rectum.
There's a lot of time. The topic is open to discussion.
Once in a while, every surgeon will have a occasion to remove the Gossypibioma or textoderma, or he may put some foreign body, but never after removing it, never exposed to the public. That is a request to young budding surgeons. I had that one experience. Removed 10 years later, one foreign body removed after hysterectomy, and he put in a bottle. And the visitors are seeing that bottle throughout almost 1 week. So many consequences faced by the surgeons. So it can be happen to anybody. So be aware of that. So you remove it and dispose of our body properly. You better to get a opinion of the senior surgeon what to do in case of Gossypibioma.
Being a reference center, once in a while we are getting this kind of cases, and never we revealed the foreign bodies to the patient. We told that there's a case of infected hematoma, but in this case, unfortunately, we couldn't save that primary consultant.
So they went into court and all?
No, they paid the compensation.
Compensation.
Can we move forward, sir? Thank you so much.